Medicare costs in 2026. What you need to know. Prepare for rising healthcare expenses in 2026. Anticipated Medicare Part B and Part D premiums. As we look ahead, it's crucial to recognize that Medicare premiums and deductibles generally see an annual increase. In 2026, the premiums for Part B are projected to surge by 11.6%, a significant rise compared to the 6% increase observed in 2025. This information comes from the 2025 Social Security and Medicare Trustees Report, which estimates that the monthly premium will reach $206.50 next year. This marks an increase of $21.50, or 11.6%, from 2025, representing the largest dollar increase since 2022, when premiums rose by $21.60. Understanding Medicare Part D premiums. Medicare Part D premiums differ from those of Part B in several key aspects. Unlike Part B, which is administered by the government, Part D is offered by private insurance companies as a standalone policy for individuals enrolled in traditional Medicare. Additionally, it is available to beneficiaries who have Medicare Advantage plans that do not include prescription drug coverage. The premium that a beneficiary actually pays can vary significantly based on the specific plan they choose. This variability is why the average premium paid for Part D tends to be lower than the base beneficiary premium indicated in the trustees' report. For 2026, the base premium for Part D is expected to be $38.99. What could drive prices even higher? You might be wondering how costs could escalate further. The projected Social Security Cost of Living Adjustment, COLA, for 2026 is estimated to be between 2.6% and 2.7%. If this adjustment were applied today, it would result in an increase of approximately $54.14 per month, or $649.68 annually, based on the average Social Security check amount for June 2025, which is $2,005.05. The Social Security Administration, SSA, typically deducts the Part B premium directly from the Social Security benefits of most Medicare recipients. Consequently, this would effectively reduce the increase in the average Social Security check from $54.14 to $32.66, after accounting for the projected Part B increase of $21.50. In this scenario, nearly 40% of the monthly increase would be consumed by the Part B premium hike. What does Medicare Part B cover? Medicare Part B is designed to cover essential services such as doctor visits, outpatient care, and certain home health care services. When you enroll, you are responsible for both a monthly premium and a deductible. For 2026, the premium is anticipated to rise by 11.6% to $206.50, which is an increase of $21.50 from the 2025 premium of $185. The deductible for Part B is also expected to increase, projected at $288 in 2026, which is a $31 rise from the 2025 amount of $257. This represents an 11.2% increase, aligning closely with the anticipated rise in the Part B premium. Decoding Medicare Part D premiums. Unlike Part B, there is no single standard premium for Part D. It varies by plan. However, the average monthly premium for Part D has remained relatively stable, thanks in part to a premium stabilization demonstration established under the Inflation Reduction Act, IRA. The continuation of this demonstration into 2026 is a significant factor in keeping Part D costs manageable. The IRA's premium stabilization provision limits the extent to which plan sponsors can pass on increased costs of Part D drug coverage to Medicare enrollees through premium hikes. Specifically, it caps the annual growth of the base beneficiary premium, BBP, at 6% for 2025, enforced through increased Medicare subsidies paid directly to plan sponsors. Annual deductible and out-of-pocket spending cap. The standard deductible for Part D is projected to rise to $615 in 2026, up from $590 in 2025. A noteworthy improvement for 2026 is the annual out-of-pocket spending cap for prescription drugs under Part D, which will increase to $2,100, up from the $2,000 limit in 2025. Once beneficiaries reach this cap, they will no longer incur out-of-pocket expenses for covered prescription drugs for the remainder of the year. The importance of monitoring projected premiums. Medicare open enrollment occurs annually from October 15 to December 7. During this time, beneficiaries can switch from original Medicare to a Medicare Advantage plan or vice versa, as well as select a new Advantage plan or Medicare Part D prescription drug coverage. To maximize the benefits of your plan, it's essential to understand your out-of-pocket costs for premiums, which can vary based on your chosen plan and income level. Additionally, you may be subject to a monthly surcharge on Medicare Part B and Part D premiums, determined by an income-related monthly adjustment amount, IRMA. Your IRMA for 2026 will be calculated based on the Modified Adjusted Gross Income, MAGI, reported on your 2024 tax return. While you cannot alter your 2024 tax return, it's wise to review your financial situation to assess the risk of incurring IRMA in 2027, which will be based on your yet-to-be-filed 2025 tax return. Effective income planning can significantly reduce your exposure to this surcharge. For example, a strategically timed Roth conversion can lower your taxable income and eliminate required minimum distributions, RMDs. The Centers for Medicare and Medicaid Services, CMS, has begun to release information regarding the 2026 plan year. As we approach the announcement of new premium and deductible amounts, the CMS has implemented new rules and updated existing figures in preparation for the upcoming open enrollment season. Be sure to check out the 6 Medicare changes coming in 2026 and revisit periodically for updates as more information becomes available. Disclaimer: the projections for Medicare Part B and Part D premiums for 2026 are primarily based on the annual Medicare Trustees Report, while the final figures are typically announced by CMS in October of the preceding year, October 2025, for 2026 premiums. The Trustees Report provides reliable estimates. Related content: prior authorization coming to traditional Medicare starting in 2026. Humana to cut prior authorizations for Medicare Advantage plans by 2026. 6 changes coming to Medicare in 2026. 4 proposed changes to Medicare in the One Big Beautiful Bill Act, and what ended up in the signed bill. Medicare Part D premiums skyrocket in 2026. Your action plan. Millions of Medicare beneficiaries are quietly approaching a serious and unexpected challenge concerning their prescription drug expenses. Although the Medicare Trustees 2025 report has confidently labeled Part D prescription drug coverage as being in satisfactory financial condition, the reality behind the scenes tells a different story. The Centers for Medicare and Medicaid Services, CMS, has now found it necessary to take urgent steps to curb rapidly increasing premiums for 2026. But here's where it gets controversial. This situation highlights just how precarious the program has become and why beneficiaries must be more vigilant and proactive in the upcoming fall enrollment period. Why are 2026 Part D premiums set to soar? Despite the optimistic tone from the trustees' projections, insurance providers submitted bids for 2026 that came with sharply higher premiums. The national average monthly bid amount, NAMBA, jumped drastically from $179.45 in 2025 to $239.27 for 2026, which suggests base premiums could rise to a level many beneficiaries will find hard to accept. However, if we look back at 2025, the actual base premium paid by beneficiaries was much lower than the NAMBA. For instance, while the 2025 NAMBA was $179.45, the base beneficiary premium was only $36.78. This discrepancy is important to understand, as it represents the difference between the average cost insurers bid and what consumers actually pay. So, what exactly is the national average monthly bid amount? NAMBA is a figure calculated by CMS that reflects the weighted average cost estimates from all insurance plans participating in Medicare Part D. Think of it as the average monthly price insurers expect to charge to cover prescription drugs for one person. The average is adjusted according to how many people are enrolled in each plan, providing a kind of market-wide benchmark. For the very first time in Medicare Part D's history, CMS has rejected some standalone plan bids due to unacceptable significant increases in cost sharing or reductions in benefits. To counterbalance the premium surge, CMS has extended an emergency measure called the Premium Stabilization Demonstration, which limits how much monthly premiums can increase. However, even this cap is rising, from $35 in 2025 to $50 in 2026, meaning beneficiaries could still see significant hikes. The Inflation Reduction Act, a double-edged sword? The new premium turmoil can be traced largely to the Inflation Reduction Act, IRA. Originally crafted to protect seniors by capping their out-of-pocket prescription drug costs, this well-intended policy has triggered unintended consequences. The 2025 benefit redesign under the IRA introduced several major changes. An annual out-of-pocket spending cap set at $2,000 for 2025, rising to $2,100 in 2026. Increased government responsibility for catastrophic coverage expenses. Added pressure on insurers' pricing strategies. While this cap is a lifeline for roughly 5% of beneficiaries with very high drug costs, the other 95% of Medicare recipients face higher deductibles, increased coinsurance costs, and more unpredictability in premiums. For example, according to the Kaiser Family Foundation, 85% of prescription drug plan (PDP) enrollees had to pay deductibles in 2025, up sharply from 67% just 1 year before. The coinsurance conundrum, the hidden expense. One of the most significant shifts is the growing use of coinsurance rather than fixed copays. Coinsurance means paying a percentage of the drug's retail price, often ranging between 25% and 33%, whereas copays are fixed dollar amounts. This is especially common for non-preferred or specialty medications. Take a high-cost medication like Eliquis as a real-world example. Its retail price can exceed $700 per month. With a 25% coinsurance, a patient might pay around $178 monthly. At 33%, it jumps to $235. In contrast, if Eliquis is categorized as a preferred drug, the copay might only be about $47 per month. Currently, most plans use copays for this drug, but the growing trend toward coinsurance means retirees could be exposed to much higher out-of-pocket costs on expensive medications if their plan's status changes. Federal interventions are trying to ease the pain, but they cannot fully cover the shortfalls created by these new policy shifts. The Medicare trustees previously assumed automatic financing and Treasury transfers would keep premiums stable, but the IRA's redesign challenges that assumption. What does stable premiums really mean? Although the average standalone Part D premium in 2025 was a relatively modest $39 per month, this apparent stability is misleading. It is heavily propped up by temporary subsidies and caps on bid increases. Meanwhile, fewer plan options are available and the market is concentrating. The top 5 insurance companies now cover nearly 75% of all Medicare Part D enrollees. This consolidation reduces competition, which may hurt beneficiaries in the long run. Low-income subsidy program erosion, a safety net growing thinner. Another troubling trend is the decline in enrollment in the Low-Income Subsidy (LIS) program, which supports vulnerable seniors with additional assistance. Enrollment decreased from 13.7 million to 13.1 million in 2025, partly because of the Medicaid unwinding process. This shrinking safety net exposes more people to premium volatility and unexpected drug costs. This is the new normal for Medicare Part D. Fluctuating premiums, higher deductibles, increased reliance on emergency federal measures, and shrinking protections for low-income beneficiaries. Your game plan to avoid costly surprises. With open enrollment for 2026 coverage starting October 15th, failing to take action could cost you thousands of dollars. Historically, many beneficiaries kept the same Part D plan year after year, with no review or changes. That strategy is increasingly risky in today's volatile environment. Why rescoping your plan is crucial. It is absolutely essential this year for Medicare beneficiaries to reshop their Part D drug plans during open enrollment, advises Mary Beth Franklin, a respected certified financial planner specializing in Medicare. She recommends basing decisions on your unique prescription medications and dosages rather than last year's premium or plan features. Helpful actions to take. 1. Carefully read your Annual Notice of Change, ANOC, which plans mail out each September. This document details any changes in premiums, deductibles, drug formularies, and pharmacy networks. Small tweaks can significantly impact your costs. 2. Use the Medicare Plan Finder tool, available at medicare.gov from October 1st, to input your prescriptions, dosages, zip code, and preferred pharmacy. This comparison helps identify plans with the lowest total annual out-of-pocket costs, not just the cheapest monthly premium. Fewer choices mean higher stakes. Market consolidation means fewer plans to choose from. Melinda Cahill, co-founder of 65 Incorporated, points out that the average number of available plans shrank from 22 at the end of 2024 to just 14 in 2025. With fewer options, the Trump administration continues subsidizing Medicare drug premiums. What you need to know. Imagine a policy that's been criticized by one political party, yet continues to be implemented by the next. This is the story of Medicare drug subsidies. While Republicans last year slammed Democrats for lowering the monthly payments seniors pay for prescription drug coverage, the Trump administration has now made it clear that this practice will continue, according to a recent announcement to insurers. But here's where it gets controversial. The Biden administration has since reshaped how Medicare handles drug costs, introducing a system that not only limits how much seniors spend at pharmacies, but also gives the program leverage to negotiate lower prices for expensive medications. For example, under the new rules, seniors can no longer be charged exorbitant amounts for life-saving drugs, and Medicare is now allowed to bargain directly with manufacturers. However, many argue that this shift could lead to reduced access for some patients, while others believe it's a necessary step to control rising healthcare costs. And this is the part most people miss. The debate isn't just about numbers. It's about balancing affordability with availability. So what do you think? Is it fair to prioritize cost savings over patient access? Or should seniors have the right to choose their medications, regardless of price? Share your thoughts in the comments below.